technical difficulties. Rebecca, can you just do a attendance call and see if we've got everybody's name anyway that's here?
Yes, one moment. Okay, so I have Abe.
Yes.
Angela Bashaw.
Here.
Jessica Schwartzman.
Here.
Amanda Wisher. Katie Cook.
Here.
Kelly Owens.
Here. Good morning.
Mark Adamick.
Good morning.
Sandy Birch. We have Summer.
Yep, I'm here.
Brenda. Lisa Tuggle.
Good morning. Yes. Good morning.
And then there's some phone numbers, so if I did not call your name, if you could just please announce yourself.
Good morning, it's Rebecca Ivansky.
Hi, Rebecca.
Anyone else we haven't called or hasn't had a chance to announce themselves?
Rebecca, it's Amanda Wisher. I apologize. My first attempt, I was muted.
Thank you, Amanda. Okay. Why don't we go ahead and get started? Since I can't see the slides, Jessica, maybe I could ask you to walk through, I think the first item is Ncqa Updates. Is that correct, folks?
Correct.
Yeah.
Okay.
Yep, not a problem.
Thank you.
So essentially, about every year, Ncqa comes out with their annual updates to their publications for the PCMH and the PCSP program. So they have done this again at the start of the month, and they released updates to both their Transforming program for PCMH, and they released the updates for the 2021 annual reporting program. So the updates to the full transitioning program go into effect on August 1st of this year. Any practices that are going through the transforming process right now have until August 1st to comply with the new updates. And any practices that are currently annual reporting practices should also be aware of these updates because they do have to attest to staying current with the program. So it's strongly recommended that everybody goes into their My Ncqa account and then go to your My Downloads section. And if you've already downloaded any version of the standards and guidelines, you should be able to see everything right there and see the new updates and download the new updates. If you've never gone in and downloaded these publications, you may have better luck going through the My Ncqa store. And if anybody needs any help with obtaining these publications or figuring out how to go in and order these and obtain them, just let me know. I'd be happy to walk everybody through that process. So changes this year were minimal. Ncqa really took into account the fact that everybody is going through the COVID-19 pandemic, that health systems are really prioritizing infection control and new policies to keep the pandemic under wraps and try to flatten that curve. So the main things that they've done this year is they've consolidated the Transforming Program Guide with the New York State Program Guide. In the past, there were two separate publications, and now they've just melded them into one and just highlighted within the full program publication which elements are New York State mandated. They've updated a number of criteria because of COVID-19, mostly to provide a lot of flexibility regarding meeting the requirements by utilizing telehealth. So this has allowed for a lot of things like same-day appointments, follow-up after hospital visit, to be met using a telehealth or a technology-supported encounter. However, because of that, you will want to go back and take a look at your policies or documented processes that you have in place for these criteria, and just make sure that your documented processes are updated to reflect the use of telehealth. So specifically, they call out TC09, which is medical home responsibilities. So if you are using technology supported visits, you will want to go back to that documented process, and also your patient materials, so brochures, flyers, websites, etc., to make sure that patients are aware that they can schedule a telehealth appointment. And NCQA has published an FAQ document just to kind of give a general sense of what was updated. And if anybody needs the link to that FAQ document or they want it in PDF form, again, let me know, but it's mostly just in their FAQ section, and they've just highlighted what changes have occurred with the transforming program. So these are, I generated a list of some of the policies that you may want to go back and take a look at and update with some language regarding telehealth. So we talked about a couple of these, the medical home information, same-day appointments. So they really said that telehealth can be used to meet this measure, along with appointments outside of regular business hours. So all of those access policies, probably a very good idea to go back, take a look at them, see if they're still relevant based on what your workflows are now. If you're planning to maintain telehealth or technology supported visits in your practice for a longer duration, then you may want to go back and update the policies accordingly.
Enter your meeting ID.
So in addition to the updates to the program, in addition to the updates to the publications themselves, QPass also underwent an update over the weekend. They made a lot of changes to try to reorganize the content so that it's more in line with the format of the standards and guidelines publications. They've also, according to NCQA, updated and improved the bulk clinician upload template. I have yet to try that out, but hopefully that has been done. Hopefully that will make uploading your clinician information a lot easier. I know there have been a number of practices that have struggled with that in the past, and it's turned into more of a manual data entry process. They've also added some historical sections and some archive sections, and included some time and date stamps so that you can see when things have not been modified and by whom. So those are some exciting changes. I'm excited to get in there and look around and see what that actually looks like in practice. They are holding a couple of Webex sessions on July 23rd and August 6th. So if anybody is interested to log in, they're having Q&As about the new QPass system. I plan to attend, and I would suggest that anybody who's working in the QPass system on any basis also try to attend and just get a sense for what is new in the system. So with that, we're working to update that tracker with any of the changes that have been made to the transforming and annual process, and we are shooting to have that available by August 15th. And if you need any assistance, just feel free to reach out.
Thank you, Jessica. Does anybody have any questions or comments? Okay. The next item on the agenda, I think, is Mark's presentation. Is that correct?
Correct.
That is correct.
Okay.
So what I was asked to do is take a look at how the PPS or how the entire region was doing on the 7 and 30-day metrics. And the best way to look at that is to go into psyches. So some of you may have psyches, some of you may not have psyches. Just to give you an overview, psyches is basically takes claims data for patients with a diagnosis of behavioral health or mental health disorder. And once your organization has billed for that patient basically goes into your roster, and you're able to see the medical history for that patient going back like 5 years. This platform, you know, I'd love to, if we had the time to go through to take a survey right now to see who's on it and who's not, but this platform basically tells you everything of what the patient is doing, what services they've received. It's an amazing platform. HCSCNI only shows you a percentage of the actual claims, but Psyche shows you everything. And especially if you are concerned about what your patients are, what medications they're on, this is it's extremely highly updated, like every 4 to 5 days. I've seen stuff update within 48 hours of it hitting the claims to the state for some measures. That being said, what we're looking at today is 7 and 30 days. So this is the screen that you'll see when you open up. In this case, it's going to show the AHI PPS. Now, the big red arrow on the left, this is the part that I wanted to show everyone. This is QI trends past year. Do you see that? So it's a drop-down menu, 2 down right there. And what it does is it gives you a graph of your metrics, depending on what metrics you choose. Now, the next page that I jumped in here, and I'm going to show you this, but what I want to point out, go back real quick. So, sorry, Rebecca. So the 2 circles I have here, and this is the point I want to make, and this is going to be a little confusing, but if you look at the red circle, you can see that quality indicator overview as of 5/1/2020. So the reports that we're going to look at are as of this 5/1/2020. However, if you look at the green circle, the DOH performance tracking measures, this is where we're pulling the 7 and 30 day. It's in this green bar, this green circle here. If you click on that, you can get to the 7 and 30 day, and then you click on that again and you can get there. But what you see here is that the data is actually from October of last year. So now if we go to the next page, once you click on the QI trends and you select the 7 and 30 day, in this case it's the 7 days, you're going to get a chart that looks like this. Now remember, Psyches is different than Disrupt. In Psyches, all the metrics, lower is better. So they'll give you a QI flag. How many people are missing, for example, an A1C? How many people did not get follow-up within 7 or 30 days? So when they give you a QI flag, it's a number of patients who missed some type of service. So in this case, every QI, for every metric in Psyches, lower is better. So if we look at the circle here, this is the point I wanted to point out. These reports, as you can see, run up all the way to May of 2020. But in essence, the real data is from October. So if we go to the next slide, zooming into that section that was in the red circle, you can see how the dates look like they're coming from May. If you go to the next slide, the actual date, if you look at the data, it's actually from October. So if you're looking at these charts, the main point of this slide here is that be careful that when you look at the data and you see 5/1/2020, people are like, oh, this is just from 2 months ago. No, it's actually from October of last year, especially for this metric. Now, I put in red here. So what I also did is I flipped the metric. So higher is better, because this is what we're trying to do, is we're trying to improve 7-day follow-up. So for this demonstration, for this presentation, I reversed it so that we could see what the metric really was. And so in this case, you can see the last 3 months of August, September, and October, there was a slight drop off. And if we go to the next slide, you can see this is the graph, the strong dark blue line, that's the PPS as a whole, and then the tiny thin orange line, that's the state. So you can see how much better we're doing compared to the state for the 7-day follow-up. You see a little bit of a drop off in the last 3 months. That part of that might be due to if you think the 7/1/19 was the end of DISRUP, and there was a huge push to try to get in patients during the DISRUP period, this might be a slight drop off from the end of DISRUP, where data and the emphasis was no longer there, but it could be another reason. If we go to the next slide, so you can pull the 7-day follow-up. Once again, it's the same situation where the report is going to say one thing, but the actual data comes from October. We also see a slight drop off here. We go to the next slide. So in this case also, you're seeing a little bit of a drop off at the end of the period. But one of the big things I'd like to point out is there's still a big difference between how we're doing compared to the state. And so that's a plus. But the main point that I want to make is that every organization can get to these metrics in psyches if you're billing for Medicaid patients. You can take a look at your metrics, and this is a sample of your full patient of all the patients that you have, because these are only your Medicaid patients. But this can give you information not only on the 7 and 30 day, but other metrics as well. There's over, I believe, 87 metrics, and I've got, if you're interested, I have materials on a definition for every one of the metrics and some more materials on how to get on psyches. So let us know if you need any help. And I think that's my last slide. So let me know if you have any questions.
Thank you, Mark. That's very helpful information. And, Brenda and I just posed a couple questions to have some discussion to kind of see where practices are at with some of the behavioral health services. And so I'm wondering if people can share, if you provide behavioral health services, what are you providing and how's it going? And then if anybody doesn't provide, how do you connect those patients?
Luann, it's Amanda Wisher. I'll share.
Thank you.
You're welcome. So we have an embedded social worker into our 6 primary care practices, as well as our 2 hospital sites. So we feel very fortunate in the fact that she's there to support our patients. However, she is very stretched thin, covering 8 sites. So that's the one takeaway that we have. We also have strong relationships with St. Joe's and Essex County Mental Health, in addition to the Behavioral Health Services North. So they're not embedded, but we collaborate on a daily basis to get our patients the care that they desperately need.
Do you find that they're able to get in a timely manner, or are we, in general, having long waits for people to get in?
So it really depends on the status of the patient. If they're in crisis mode, we can usually work pretty quickly. Somebody that's looking for counseling services may have to wait an additional time. So it's really patient specific.
Well, that's good. Does anyone else have any details they could share with their practice?
Hi, Luann. It's Lisa Tuggle here. We
Lisa.
have 2 psychiatric nurse practitioners, and then we also have a psychiatric physician assistant who the PA does med management primarily, and then our psychiatric nurse practitioners do both med management but also psychotherapy. What we've found in particular going through the pandemic is the acuity level is so much higher right now in these patients that it's requiring more time with our providers. So our nurse practitioners, we've had to do a soft close on their panel because the needs of the patient population are so much greater right now. We definitely have a waiting list. When we can't get people in, we're referring them to Citizens Advocates, North Star. But the need for more help in this area is so great.
So even reaching out to citizen advocates, there's a wait time to get people in there as well?
From my understanding is, you know, they're getting people in, but there is still a wait time there. Quite often what we do, you know, a lot of the people that we're having to refer there are people that require those wraparound services that we just can't manage
Right.
here
Uh-huh.
and provide.
Interesting. Does anyone else have any specific practices, success stories, challenges? Mhm. Let me ask another question. And I probably could have done a little survey thing that would have been helpful, but how many of you are utilizing psyches to look at any of those metrics? Or are you looking at these metrics in a different format?
It's Amanda. So we don't have psyches, so we are very reliant on our EHR. But yeah, so no
Are you
psyches
able-
here yet.
Are you able to track your 7 and 30-day follow-ups for behavioral health in your EHR?
It's a manual process, but
Okay.
we do pull reports.
Uh-huh. Someone else had a comment?
This is Ncqa Updates. We have been working on implementing psyches into our emergency department with the high-risk quality, can't remember the mnemonic for that one right off the top of my head, but initiative that New York State put together for some of the hospitals that weren't behavioral health. Anyway, so we were just about at go live when the pandemic hit, so we kind of put that all on hold. We are having a meeting next week to follow up and see where we're at with that. So we haven't yet utilized those reports, but the intent is that we will.
Anyone else using psyches or want to share how they're tracking this information? Brenda, do you have anything to add or some questions we could pose?
I think, yeah, I think, this is the opportunity. I know Rebecca Ivansky is on the call, and certainly, as we move forward and start, a lot of our value-based payment contracts that the ACO has, and some of you are, are partnering with the ACO at, at this time. I think part of it is thinking about, some of these metrics hit our value-based payment contracts. So how are we going to ensure that our patients are getting the required follow-ups after an inpatient stay, and we're trying to track, I hear Amanda, she's trying to track that manually. Are there ways that we can go about, assisting with getting access to psyches, since you are providing those type of services? And if you are billing for those services, you'd be able to track and see, what is going on and where else they're accessing services. I think, this is a time where, with the organizations that are part of, the IPA is, where are the needs and how do we start coordinating those services and working together? I think just because DSRIP, kind of where we are is how do we continue those efforts? Because there's been such great work that's been going on. And as Mark pointed out, we're still doing very well in those metrics, but how do we continue that as we go forward? So, and part of that is being able to monitor that. And it's difficult. I can say, certainly from my standpoint, I can't see what is in psych, as far as psyches, we can't see that through some of the claims because many of the payers, a lot of that information is blinded. So we're not able to see, we see it in aggregate data. We don't see it down to the patient level. So,
you know, I guess where I'm going with this is people who don't have access to psyches and are providing those services, we should think about trying to, assist in assisting you to get access to psyches so that you are able to see that if you're providing that. And then how do we, work with our behavioral health providers in the community to ensure that our patients are getting connected. So, it's really how do we continue moving forward with the great work that's been done, and then where are the gaps, and trying to bridge those gaps as we go forward, with the services we have, and trying to identify other potential resources for us.
Good morning. This is Rebecca Vansky. Thanks, Brenda. So on the curtails of that, I completely agree. I think that in listening to even this discussion this morning, and thank you for inviting me once again, to hear just at the simple level of wait times and making sure that we put priority understanding around the patients that are of greatest need and getting them in. So this gives me the ability to go back to our providers and talk about what that looks like. Is there a way we can improve that process and get folks fast-tracked, or even bring some information back to this group if there is a workflow improvement on our members' end that can get your patients in. And then additionally, I always love Mark's presentations. Thank you, Mark, on the psyches information. I think the continued challenge and discussion is that the data is older. It's from potentially last October, but that you can do that drill down, and all of our partners have access not only to their own psyches, but to a network, so Northwind's provider network aggregate view to see how we're doing. So I think offline, I'd love to connect with Mark and see if we can get some permissions or something in place where you can maybe even help our partners along with understanding that better. I think there are still some who are challenged with it, but we can do better in being able to look at it, identify those gaps, and then connect not only to to primary care essentially, and make sure that they stay engaged in services.
Thank you very much, Rebecca, for that information. Go ahead.
Luann, this is
I
Mark.
was just, smart.
Oh, go ahead.
No, I think the big challenge, and I know for everybody that's on the phone, and I think one of our biggest challenges, and I'm going to just say, from the provider standpoint, one more place for me to go look for something, because I can honestly tell you, working with all the different payers, so you have different portals for payers that you have to go into, and then you have different, you've got to go into the immunization registry and enter this, and you know what I mean? There's just so many places. So I think understanding the value of what that, brings, it's just, I can understand from the provider side, it's another place. And I think for some of the hospitals, the complexity of the turnover and changes, I'm just speaking, over the course of time, as you have the turnover in staff and getting the access and continuing that access, sometimes that becomes a little daunting too. Do you know what I mean? So I completely understand, but then the value behind being able to access that information, down to the individual person that you're looking at, certainly is helpful for the overall picture of that patient.
Thank you, Brenda. This is Mark. So one of the things I wanted to point out again was the metrics. What the state does is it gives the providers a chance to get all their data in before they report on the metrics. That's why the metrics are in a sense delayed, by a couple months. However, the data that's going into psyches is, as soon as the claim hits the state, it's basically getting uploaded to psyches. So one of the examples that I often give is, imagine a patient goes into the ER and says, I'm schizophrenic. The doctor or the intake may say, okay, what medications you're on? Oh, I didn't bring them. Do you know the names of the medications? No, I forgot them. Do you know anything about what you're on? No, I don't. And so if the organization has psyches, They go into Psyches, they can see every medication the patient's on, who gave him the medication, who gave the person, he or she gave the medication, and they can make that determination at that time. So this is one way where you're definitely getting as much. Now, if the person, granted, if the person got medication the day before, that's not going to be there. But for the most part, this data is coming in as soon as and medications go upload faster than anything else because pharmacies want to get paid as soon as possible. So they're sending stuff in as soon as they fill the prescription. So you're looking at a fast turnaround on that data. But I just wanted to point out that there's a difference between the metrics and the data. The data is updated as soon as the claim hits.
Thank you for that information. Brenda, did you have a comment you wanted to share?
Oh, no, I had said it before.
Okay.
Thanks.
Anyone else? And I guess I'm going to offer up Mark, put you on the spot there, but if you want to have some assistance with getting Psyche set up, at least, you know, from your own perspective, that you can start to go in and look, you know, Mark is a great resource to help you get there. I do know he's helped many of our partners. So I certainly will offer up his services if you all would like to give it a try. Or if you even need to figure out how you can get there. I know Psyches has been definitely broadening its horizons with people getting connected and who can get connected. So it might be a good time if you're thinking about it. We can certainly lend some help.
This is Jackie from Nathan Tower.
Hey, Jackie.
Hi. Is primary care, do they have access now? Because it used to only be if it was like the emergency room, like hospital side, or mental health in general. Primary care wasn't eligible to have access. Has that changed yet? I know they were working on it.
I agree, Jackie. I know they were working on it. I can't tell you with 100% certainty, but we can certainly reach out and see what's up with that and get some information back to everyone. Mark, do you know off the top of your head if that's been pushed through yet?
No, I know they were working on it, and then, you know, the COVID happened, so I don't know if it got pushed to the side or not.
Yeah. We'll follow up, Jackie, and see what we can find out and let everybody know. Because to your point, they were working on it. But I think we've had that challenge with every organization right now in healthcare about what their focus is and what it isn't.
Right. And it's you know, we do have, our hospital does have access, but it's tough because, you know, the case manager that has it is, you know, she's got her own job. So for me to ask her to run reports, for me, I'm technically primary care. I really shouldn't be getting that stuff.
Right.
So this is,
and I didn't realize that you were connected to a hospital. We were under the impression that through the High Risk Quality Collaborative with Psyches that because our primary care is connected to the hospital, even though we're not behavioral health, that it was still okay for our primary care to utilize it.
This is Jack, not from what I read about it, and when I talked to somebody at Psyches, the answer was no.
Okay.
Yeah, we'll do some follow-up, folks. I'm going to ask Mark to take that away. Could you follow up with that, Mark?
Yeah, let me look into that.
Thank you so much.
Okay.
I know from a state perspective, and I'll raise it too with the state committee that I work with to see if they were going to push that, because it has been mentioned several times that, you know, it shouldn't be really just for those that provide that specific service, because we're not doing a justice to the patient by guarding who has the information. But again, if they don't have the consents, then we're also limited.
Yeah.
There is some work being done in general around the whole consent piece. I don't know that I've ever shared that, but let me put it on my to-do list and see if I can't get you all an update. Two venues that are kind of happening is statewide. We're trying to figure out if we can't push a one common consent. So if it's signed once, then it's good for all. And then the other is there's new language in BAAs where if you have a BAA with a certain provider or partner, you're covered under that to be able to find out information about the same patient populations. So I'm going to see what I can pull together and provide some concrete information for you all. We really are pushing heavy at the state level to get one consent. And obviously, idealistically, we'd love the opt-out path, but it hasn't come to fruition yet. Okay, so we'll follow up on the psyches, and I'll also see if we can't get some further information about consents in general and how people can or can't get into information around various clients and patients. Any other comments or thoughts or questions that people might have on this particular topic? The other thing I wanted to mention, and I apologize, Rebecca Avansky, for not introducing you, but Rebecca Avansky is, and I'm going to ask Rebecca to talk to herself because I don't have all the details, but she now is working with Northwind's IPA. And so in our further efforts to collaborate, we've asked her to join this group, and even from the perspective of the partners she's working with, we feel like it might be a good addition to have some of those behavioral health groups right at the table here so they can understand what the practices are going through, and even have some, maybe, real-time discussions about how we can further collaborate to provide the care that our patients need. Rebecca, do you want to, I'm going to put you on the spot, you want to do a little intro of your role and what's going on in the Northwinds?
Yeah, sure. So thanks, Luann, and certainly I should have done an intro too before I was just sharing earlier. But so I've been part of practice transformation I know there are very familiar names on the call, and spent many years working with AHI on mental health and addiction treatment initiatives under DISRIP. And coming from a direct service background, it was really a good opportunity for me in taking on the Northwinds role. So if you're not familiar with the Northwinds IPA, it's a group of 14 behavioral health and substance addiction treatment providers across the North Country region. So it would be the DISRIP footprint, with the exception of we don't have providers in Saratoga or Fulton County currently. And I will say, in a groundbreaking recent achievement, along with the ACO, we entered into a level 2 value-based contract. So even more important as we move forward to be looking at not only quality and the metrics even that Mark mentioned today, we want to make sure that the providers who come to the table are able to, really support the work that you're doing in the hospital systems to lower those unnecessary emergency visits, the readmissions, but also make sure we're getting folks into treatment in a timely manner. So I think it's all very applicable as we move forward. I hope to have some providers at the table that can help along with your initiatives under practice transformation. So I guess I'll leave it there. I'm welcome to questions, or if you want to talk offline, we certainly can around some of our quality metrics. But with regards to the psyches, again, I'll just revisit. I'm not familiar with the primary care practices, having had access in my expertise in working with Mark at AHI on the psyches initiative, but certainly I will say that our providers have shared, many of them have it right in their initial workflow to look at things like medication that Mark hit on, but also recent hospitalizations or ER visits. Their connectivity to a health home or care management is listed in there.
So I think we're making good progress in the things that we can use psyches for, that they are checking it as part of that intake workflow. But I still think, of course, we have some work to do in making sure we're well connected to other providers in the community. Thank you, Luann.
Thank you, Rebecca. Anyone with questions for Rebecca at this point? Okay, and her email is in this email train, or if you need contact information, we can certainly provide that for you all. Any other conversations or questions, topics, discussions around this particular item? Okay, it is 1:15. I just wanted to leave open some time in case people have additional questions or any things they might need some help or support with. I do know from the last meeting, I had a couple takeaways that I've been working on between NCQA and payers and getting the systems right-sized. As many of you may know, everybody is so focused on COVID. It has been a little difficult to ask people to focus on something else. So I have been persistent with my requests, just haven't got enough answers that I'm comfortable with either. There has been just recently, as Rebecca shared, the update to QPass, and I was informed that some of those errors that have been occurring or those mismatches that have been occurring should have been straightened out. So I do plan to go look in there myself today or this week. Just haven't gotten there yet. I don't know if anybody has anything that they're looking for some support with, or questions, or just, you know, things that they've discovered that might be helpful for others.
Hi, this is Katie. Good morning, everyone. I just wanted to remind everyone that we have released our new Telehealth Technical Assistance Center website, which you can find through the link that's on this slide. We've put a lot of great resources and time into that website. There's also an upcoming events and webinars section, as well as links to all of the different agencies at the state and their telehealth guidance. So please take a look at that site when you have time, provide feedback. There's also an interactive map on there of all of the telehealth programs in our region. And I am in the process of collecting Q2 telehealth data. So many of you likely saw my email about a week and a half ago. We are looking to collect encounter and telehealth visit type data for April, May, and June. I can tell you that just based off of 11 partners submitting data so far, we've already tracked over 25,000 telehealth encounters in 3 months, which is pretty mind-blowing. So kudos to all of you for your hard work. And feel free to reach out to me with that data. We'd love to track that.
Thank you, Katie, and thanks for calling that out. Again, too, I've asked Katie to join this meeting regularly, as there's always, you know, the telehealth is evolving. So she's been a great addition, and again, a wealth of information. If you need any help with the telehealth piece of it, it's certainly Katie that I would recommend highly. Anyone else with questions or feedback? Brenda, any last words?
I'm all set, Luann. Thank you.
Okay. Well, I'm going to give everybody back at least 10 minutes of their morning, and I thank you all for attending. Stay well, and we'll talk to you soon.
Thank you.
Thank you. Thank you. Thank you.